afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on the characteristics of substance-related toxicity deaths in Ontario. My name is PWLLE. I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I'll mention a few housekeeping items. The chat pod is disabled to limit distractions during the presentation. You can use the Q&A pod if you have questions during the session, and there will be a discussion and question period following the presentation. If you have any technical issues during the presentation, you can email capacity building at oahpp.ca. And I would like to state that as the moderator of this session, I do not have conflicts of interest to disclose. It's my pleasure to introduce our presenters, and I'll share a bit of their bios here and then turn it over to our expert presenters. So today's speakers are Tara Gomes, Ashley Smoke, and Tasha Dawn Doucette. Tara Gomes is the Scientific Director of Urban and Community Health at Unity Health Toronto and Principal Investigator of the Ontario Drug Policy Research Network. Ashley Smoke has over 7 years experience in harm reduction and AIDS service organizations. She's the founder of Northumberland Drug User Group and co-founder and VP of the Ontario Network of People Who Use Drugs, a board member for the Canadian Association of People Who Use Drugs, and has participated on many research projects with ODPRN and other organizations. She sits on the ODPRN Lived Experience Advisory Group and the People with Lived Experience Council for Public Health Agency of Canada. Tasha Dawn Doucette holds a BA in Criminology, Criminal Justice and Law, and is in her 4th year toward her BA Honors in Law with her eyes on Masters. And sadly, her family and loved ones are dying from drugs regularly. I'll pass it over to Tara at this point, and thank you for joining us today.
Thank you, Cam, for that introduction. And thank you all for joining us today. I'm really pleased to be here presenting with both Ashley and Tasha Dawn to discuss some of the findings of the recent report that we released, and as well as making sure that we have the time to really hear about the expertise and advice that comes from both Ashley and Tasha Dawn on this topic. Before we get started, I do want to start this round's presentation today by humbly acknowledging that I am an uninvited settler on this land, and this land has been a place of communities coming together for thousands of years. I'm joining from Toronto, which has been the traditional territory of the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and most recently the Mississaugas of the Credit. Today, this land is home to many Indigenous people from across Turtle Island, and I'm really grateful to have the opportunity to live and to work here. I also want to acknowledge the historical, current, and continuing impacts and deep harms of colonization on Indigenous children, families, and communities, and recognize the need for us to strive to really actively work to learn about the history of this land and the truth of this place. And I acknowledge that we all have a role to play in advancing truth and reconciliation. As a settler on this land myself, I'm really committed to expanding my knowledge of colonization and the impact it's had and continues to have on Indigenous peoples across this country, and to using my privilege to advocate for more voices of Indigenous people and other underrepresented groups at all tables. I also think it's really important with this talk today to acknowledge that the drug toxicity crisis across Canada has disproportionately impacted Indigenous people, and a lot of that is a result of the current and continuing impacts of colonization, including the deep harms of the residential school system and the resulting intergenerational trauma. I also really want to take time to honor the memories of our community members, our friends and families who we have lost to this drug toxicity crisis that we're facing across North America, and to reiterate my commitment to working with communities and people who use drugs, to use my privilege to advocate for bringing their voices to the forefront in all of the conversations of which I am part. I think today we do talk a lot about data and statistics, at least in the part of my presentation. I think it's really important for us to remember that these numbers and statistics all really reflect enormous loss of life and trauma for many people across this country. In terms of disclosures, none of the presenters of the session have received financial support or in-kind support from commercial sponsors. We do have some conflicts of interest to share that I have listed on this slide, primarily for myself, stipends and funds from publicly funded organizations like Indigenous Services Canada, CADA, the Ontario Ministry of Health, and CIHR, which has helped to support some of the work presented today, as well as the broader work of my research program. And for Tasha Dunn and Ashley Smoke, they have received stipends as members of the Lived Experience Advisory Group for the ODPRN. We did share this presentation ahead of time with Public Health Ontario to make sure it was reviewed, to make sure that the principles of integrity, objectivity, and balance were respected. So just to start, with respect to the report that was released yesterday, we really engaged and started to work on this report because we recognize that alcohol and drug toxicities continue to be an enormous public health concern, both here in Canada and globally. But there has been very limited data, especially here in Ontario, about the specific roles and contributions of various substances. And we were really fortunate to be able to work with the Office of the Chief Coroner here in Ontario, as well as Public Health Ontario, to, for the first time, get access to data on all toxicity deaths related to alcohol, benzodiazepines, opioids, or stimulants that occurred across Ontario between 2018 and 2021. And that allowed us to not only look at trends and combinations of substances that have been involved in these deaths, but also to understand some of the characteristics around these toxicities that can help to inform responses. I won't spend or dwell too much time on methods, just to reiterate that these data are collected by investigating coroners in Ontario and capture all substance toxicity deaths that I mentioned. So in the past, a lot of our work has focused on opioid-related deaths that may or may not involve other substances. This report, for the first time, allowed us to look at all substance deaths. So for example, stimulant-related deaths that may not include opioids, or alcohol-related deaths that may not include opioids. And we were able to link these data to sociodemographic information at ICES to be able to better understand some of those factors as well. This is a large report. I don't plan to go through all of the findings. Hopefully everybody on this call, if you're interested, can look at the report and the accompanying infographics to get more detailed information. It's very hard to capture the nuance of all of the information across these 4 substances, but what I'll just try and do over the next 15 minutes or so is just touch on some of the main elements that we thought were important for this discussion here today. So first of all, when we look at these substance-related deaths that occurred between 2018 and 2021, we found that over that 4-year period, there were nearly 9,000 deaths in Ontario. So that equals about 1 in 8 deaths every single day in this province in 2021 that were from a substance toxicity. And I think that's really important to take a moment to reflect on, because it is an enormous number of deaths that we are seeing across this province. We see that a lot of those deaths, about 85%, involve opioids, but there's also a large proportion that involve stimulants, with or without opioids, and then between about 9 and 13% that involve benzodiazepines or alcohol. So for those of you who chose opioids and stimulants, you're right. So that is actually the type of substance toxicity death that is most prevalent in Ontario, and that has actually increased most quickly during the pandemic. So in the pandemic period, about March 2020 to December 2021, about 43% of all of the substance toxicity deaths in Ontario involved both opioids and stimulants together. And you can see that then deaths involving opioids alone or stimulants alone are also quite common. One of the important shifts that we saw in the pandemic was really this shift towards more polysubstance use, or more toxicity events that occurred in more than one substance. So as you can see in this figure, before March 2020, there are similar proportion or rate of toxicity deaths that involve just one substance or 2 substances. And we saw after during the pandemic, I should say, that there was this quicker rise in deaths involving 2 or more substances, which I just think is important to flag, because it really does show that the way in which people are using substances and the harms that came from that really did shift during the pandemic. And we are in a situation now where we're seeing increasing harms from the use of multiple substances together, which speaks to our need to think about our responses and how we adapt to the fact that, historically we spent a lot of time talking about opioids, but we need to make sure that we're also thinking about the other substances people may be using and how to best support people in terms of providing access to programs and services they may need around use of opioids, but also stimulants, alcohol, and benzodiazepines. And when thinking about those responses, some of the ways that we've really been trying to frame this is thinking about, what populations are most being impacted by these deaths, what are the circumstances and contributing factors that might differ across different toxicity deaths, and how can we use that information to identify what opportunities exist to improve or tailor the responses that we have available across Ontario and more broadly across Canada when we think about substance-related harms. So in this report, we do try and delve into some of these elements. I'll also note that this is the first of a series of 3 reports. And so the subsequent reports are going to go even further into looking at people's connection with the healthcare system and access to treatment. In this report, we were really focused on understanding the basic circumstances around death and the demographic situation for people who were experiencing substance toxicity deaths. In general, across all toxicity deaths in this report, we found that on average, people are about 40 years of age. About 3/4 occurred among men, and we do consistently see this concentration of harms occurring in more concentrated forms in lower income neighborhoods across the province. However, we do know that the circumstances in these various demographic elements do differ based on the types of substances that are involved in these deaths. And so in the remainder of the report, what we did was have snapshots and focused analyses on each of these 4 different substances. I think it's important to note that these are deaths where alcohol was identified as a direct contributor to death. There may have been other deaths where alcohol was detected but was not determined to be a direct contributor, and that would not be included here. But when we think about alcohol as a direct contributor to death, that occurred in 13% of all of the substance-related deaths. We have seen, if we look over time, this increase in alcohol toxicity deaths that occurred early in the pandemic. And that aligns with some other evidence that has come out throughout the pandemic around changing patterns of alcohol use. Alcohol sales increased as well over this time. And we know that there were changes just in people's isolation, their ability to kind of have those contacts and connections with others that can influence the way people use substances in generally, and specifically we have seen as an influence the way in which people used alcohol, especially early in that pandemic, where we do see this rise in alcohol toxicity deaths. We also see that the percentage of deaths that do not involve opioids has been declining over time. We also see the absolute number of deaths that do not involve opioids is also declining over time. So we have seen that alcohol-related deaths are primarily events that happen when people are using alcohol with other substances. So only 8% of all of the deaths that we saw for alcohol toxicity involved only alcohol without at least one of these other 3 substances. And when we look specifically at these alcohol-only deaths, we do see that in general, they tend to occur in people who are slightly older, for example. We see similar rates, though, across urban and rural environments, and similar rates among men, where about 3/4 of these deaths occur among men. When we look at the stimulant toxicity deaths, we do see some different patterns over time. We have seen, again, this increase during the pandemic in stimulant-related deaths, but those have really been sustained. In contrast to the alcohol-related deaths, where we saw more of a short-term increase, we've really seen this continued and sustained increase in stimulant toxicity deaths during the pandemic. We also see that there were a large number of these deaths. There were 1,843 stimulant-related deaths in 2021, the majority of which involved cocaine or methamphetamines. And we also do see that there's, about 17% of these deaths that also involve a combination of cocaine and methamphetamines. The other important element to this is that we do continue to see a growing role of opioids in these deaths. As if you think back to the first poll, opioids and stimulants together are consistently the most common situation when we look at substance-related deaths, and we can see how that has changed over time, such that only about 17% of the stimulant deaths that occurred in 2021 did not include an opioid. This just really, focuses in on some more details related to that, where we do see that primarily stimulant-related deaths also involve opioids, although we do see about 1 in 10 deaths that also involve benzodiazepines or alcohol. And the demographics are actually quite consistent here with what we saw in alcohol-related deaths, and as you'll see in many of the other substance-related deaths, where on average people are about 40 years of age. About 3/4 of the people are men who experience these harms. Two other elements that I think are important to speak briefly to are the proportion of these deaths that occur in private residences. About 3/4 of stimulant deaths occur in private residences, and again, that's quite consistent across substances. And this really, I think, speaks to the fact that the stigma that comes from substance use can often lead people to hide their use, to use drugs while alone, and that can really increase the likelihood of harm if there's nobody there to intervene if there is a problem. And so this is something that we've seen in our past work looking at opioids, and it has consistently continued throughout this work, and really speaks to how we need to consider access to community-based programs that are accessible to people, as well as destigmatizing substance use and opening up those conversations so that people aren't led to use substances alone and in situations that could lead to a lot of harm if there's nobody there to help them. We also see that there are higher rates of these harms in Northern Ontario compared to Southern Ontario. The rates are about 3 times higher for stimulant toxicity deaths. And that is actually also quite consistent across the various different substances that we looked at. And I think this really comes back to not only accessibility of different services in more rural and remote regions, where we really need to be a bit more creative and make sure that there are investments into services that will meet the needs of people that are more geographically dispersed. But also, as I mentioned at the very beginning of this presentation, the long-term impacts and ongoing impacts of colonization and the intergenerational trauma that exists among many First Nations people who do live in Northern Ontario, and the need for us to make sure that there are investments in First Nations-led and Indigenous-led responses that really meet the needs of those communities as well. When we look at benzodiazepine toxicity deaths, there are some differences. We again see this increase during the pandemic in benzotoxicity deaths. The number of deaths are quite a lot smaller. There were 239 deaths in 2021. But I think it's really important to flag that the majority of these deaths, over 80% of them, involve non-pharmaceutical benzodiazepines. And almost all benzotoxicity deaths involve other substances, primarily opioids. And this really reflects what we've seen begin just before the pandemic and continue during the pandemic of the arrival of non-pharmaceutical benzodiazepines into the fentanyl supply. They really increase the sedating effects of fentanyl. They really complicate the response to overdoses because naloxone obviously only works on the opioid component of a toxicity event. And it also just really highlights the unpredictability of the fentanyl supply right now and the dangers and harms that can come with that. Finally, we can't, of course, talk about substance toxicity deaths without speaking about opioid-related toxicities. We have presented this in past PHO rounds, and probably this is the element people are most familiar with, so I won't spend too much time on this except to say that we saw over 2,500 opioid toxicity deaths in 2021. The numbers increased during the pandemic, and they've continued to stay high. More recent data from the coroner's office throughout 2023 has perhaps shown some indications of slight reductions in opioid toxicity deaths, but the rates continue to be much higher than what we were seeing prior to the pandemic across Ontario. It's really important as well to remember that these are deaths that involve primarily non-pharmaceutical opioids, usually fentanyl, that is predominantly what is in the drug supply right now. And we often do see combinations of opioids being used with stimulants, benzodiazepines, and alcohol across both those deaths that involve pharmaceutical opioids as well as non-pharmaceutical opioids. So I'll just wrap up my element of this presentation to say that I think the data in this report, and hopefully I've been able to highlight the main elements of this presentation today, really identify the complexity of substance-related harms across Ontario. We are seeing rising polysubstance use, which means that people are being exposed to multiple different substances and likely need supports and services related to those different substances. So we have to make sure that our healthcare providers and healthcare settings are really trained and equipped to be able to meet people's needs, not just around perhaps the treatment options that they may need or the access to harm reduction related to opioid use, but also stimulants and benzodiazepine dependence that people may have if accessing the fentanyl supply, as well as combined alcohol use disorder diagnoses that people might have. So we need to make sure that people are equipped to recognize these various substances that people might be using and the supports and services that they might need to make sure that they're staying safe when using these substances. Finally, we do consistently see these higher rates of harms that are occurring in Northern Ontario. A lot of our services are focused in more urban centers where we have concentrated populations, and it's simpler to integrate these services. But I think it's really imperative that we think about how these responses can be adapted to more northern and remote parts of our province, and how we can make sure that the kinds of services provided are meeting the needs of the populations that are looking to access them in Northern Ontario. So before I pass this over to Ashley and Tasha Dawn, I just want to acknowledge that this was really a group effort among many people who contributed to this report, and take a moment to acknowledge all of the efforts of everybody who came together to help us pull this work together, as well as thanking the Office of the Chief Coroner for providing us with this data and ICS for their support in helping to link this data and make it accessible to us. I've included our contact information here, and I'm happy to also include that in the chat later if people are looking for them. But want to really thank Ashley and Tasha Dawn for being here today and for being willing to speak to the community response and their lived experience, because I've learned so much from both of them and everybody with lived experience who I've been fortunate to work with on this report and other work, and really appreciate you both being here to speak to this experience. So I think what I'm going to do right now is stop sharing my screen and pass it over to you, Ashley, so that you can share your thoughts.
Okay, so I guess I'll just start by saying, like Tara said, we're not in an opioid crisis anymore. It's like the whole illicit drug supply is the crisis now, and a healthcare crisis, and like all these different things. And we need to focus more on like other drugs as well, not just opiates, because like in my experience, so many people like drink, smoke meth, smoke crack. I know so many people who don't even do opiates, but they've still overdosed or at risk of overdose. So I think it's important that we focus on the whole supply now and like all the drugs that people are taking, because fentanyl, fentanyl is not killing my friends anymore. They need fentanyl. They need prescribed fentanyl, and they need to get off of the unknown supply of what is called fentanyl, but is all these other things mixed in. And so like in terms of like we need prescribed fentanyl, but we also need like other forms of regulated supply that might not be prescription, so that people have access when doctors aren't open, or if they don't want to see a doctor for whatever reason. Also, I'm seeing that folks are getting like really bad infections from like the benzos and tranks, but also they're just living rough, and like healthcare turns them away when they have wounds and infections, and they go and live outside. Like they get turned away and go out, live outside, and they get dirty and no one comes and cleans them. And it's the community members that are providing the wound care at this point, not like the people who are trained to do that in school. So I see so many people at risk of like death, and they might have a lot of drugs in their system, but there's so many people that are dying of like non-overdoses or non-toxicity deaths, but they use drugs still. So we need to like focus on like a holistic approach, and like a lot of options. Like so many options are necessary. We need as many treatment options as possible. We need strategies like harm reduction, safe supply, compassion clubs, ethical dealers, OPSs, CTSs, rehabs, detox, health services, and we need them all like concurrently, and like you need to be able to go to them like all fluidly and at the same time and move throughout the continuum like you need to, and not based on the policies that they've created thus far. So we need to remove a lot of barriers, and part of that is removing barriers that like workers face when trying to refer clients to abstinence-based treatments just because they practice harm reduction. And that's part of like removing stigma and making a place safe for people who use drugs. The political climate has made it really dangerous to be someone who uses drugs if you have no shelter. It's like a downright violent and degrading experience sometimes, and it perpetuates the shame that we face, especially when they're evicting and criminalizing homelessness and villainizing poverty in the media. It can be really like a toxic environment with all the vigilantes and like people who openly take matters into their own hands and act in ways that like harm people who use drugs just to feed their NIMBYism. So like in my town, often the organizations that work with folks are not actually trying to help, but like appease leadership, and they refuse to stand up for the folks who need them the most, who are like the most marginalized folks who are targeted by, and those folks are also targeted by lawmakers, and they're like used as numbers with these organizations to receive funding and accolades. And then if you ask like the people who use drugs what leadership and what the organizations who are tasked to help do, they say nobody's doing anything. So like there's a very big disconnect between the people who make decisions and the people who are on the ground who are impacted by the decisions. And when it comes to that, Indigenous people are overrepresented in terms of like drug use and deaths and whatnot, and we're the largest growing population. So like we need to recognize that we're in need of a major overhaul of the way that we work with Indigenous people if we're going to survive and thrive in this country, especially in terms of like how we work with Indigenous people who use drugs. So like we really need Indigenous harm reduction and Indigenous specific or culturally relevant programs and services and strategies, policies. We need like a holistic approach as well. Like we need, for me, I wasn't able to get well until I was able to work on all the aspects of myself, like emotional, spiritual, physical, mental, and I had to do it all at the same time. It couldn't be like, oh, we'll focus on your physical first, the methadone, and then we'll focus on your spiritual or your mental next, which is like the psych meds. And then like, you know, we need to do it all at the same time. People need to have a holistic approach to their care. And then also we need to treat people like people and not numbers, as well as like backing like the movements of people who use drugs, like safer supply and unsanctioned OPSs and all the things that are being villainized right now in the media, because people who use drugs will continue to die at increasing rates if we don't stand up with them and for them. And yeah, that's what I have to say. Thank you.
All of you. Sure, that will lead to questions in the group, but I think what we'll do next is ask Tasha Dawn to join us. Yeah, hi Tasha Dawn. Oh, you're muted still.
Hello, can you hear me?
Yes.
Great. Hi, my name is Tasha Dawn Doucette, and I am currently on unceded Algonquin territory. I want to thank everybody who came, and I would like to thank everyone who is a part of the study. Mental illness and addiction have maintained a significant and continuous presence in my life. I'm 45 years old, and it has been a lifetime of addiction, mental illness. Mental illness and addiction were bullets I could not have possibly dodged. Where I was born, the world that I grew up in was we faced mental illness and addiction, and it was progressive back, when I was a teenager, and then I was definitely a part of using for quite a while, and I'd stopped, but why I stopped was my rock bottom, and I believe that no one knows what anyone's rock bottom looks like. So we don't know, because everybody's different. But as a consequence of my journey, it has been marked by a lot of pain, suffering, and grief beyond description. I prepared this brief presentation because it was difficult for me, because I could write many books on addiction and mental illness. I decided to read off my notes, and Tara's here to help me get through. My sister would have probably been in about ICU 4 years ago. She passed away from using fentanyl, and there's a lot of stuff around that, a lot. And so with these numbers, I'm definitely devastated by the reality that we're facing today. Because what I said, it was progressive. It's like, whoa, it's like the nothing and the never ending story. It's like, it feels, like that war on drugs, the drugs have won. It's just overwhelming to see like to witness the growth of it, and the impact on families, communities, friends, people. It doesn't discriminate. It goes into all places, and sadly it does hit hard low income, like myself and my family. I think that people are suffering mentally and physically. Well, I know they are. They're suffering. And mental health services are beyond inadequate. They don't make sense. Medication, it's helpful, but we need a lot more help in this area. And so and physical as well. So physical pain, mental pain, suffering is pushing people to self-medicate and also go out and look for drugs. And then, the cycle begins. And it affects a lot of people, even funeral directors. When I was at my sister's, before her vigil, my husband and I had went in and did a journey song, and it was a singing and drumming, just the two of us. And the funeral director was like, after, thank you so much, what they're going through, what they're seeing, where these people are coming in, where no one's actually claiming them. These types of things must be just awful for people on that end as well. I'd like Tara to ask me questions so that, I can help, if I can help at all.
Yeah, Tasha Don, I know that, first of all, thank you for sharing all of that. And I know that that's not easy to share. I know we've talked in the past about, what you think the healthcare providers, doctors and other, hospital settings might need to do to better meet the needs of people who are using drugs, and people often who might be using multiple substances. Do you want to talk a little bit about your thoughts about what doctors and what the healthcare professionals can do?
So the introduction of controlled substances is the most important part of the journey for a person that's going who's suffering. And I think, we need to increase, obviously, doctors. We already are aware of that anyways. We were just at the hospital for 15 hours and there was one doctor, and this is in the city, at the emergency. So, I mean, it's a big ask, but we need people to fast track people who are in addiction programs rather than, you know, take half of that program and put it into a mentorship or a field placement program for addiction workers, so that, you know, people know that you can't really read your way into this. It's very much a, like, when you're working and when you're walking beside people who are suffering with addictions, that you know, it's really that experience of being there that makes the people who are working far more effective, I guess. And it's definitely about inclusion and compassion, of course, and this connection that is causing so much suffering. You know, there's this lack of connection. So there's so much that there's so many different approaches. There's abstinence, there's harm reduction, and I think it is unacceptable at this point for anyone for a person who's seeking help to say, don't go to that one or don't do that one. There shouldn't be any negative talk around any kind of you know, support for a person who's suffering, because all hands on deck right now. We're in trouble. We've been in trouble for a while. We're in trouble now, and it's big trouble, and it's heartbreaking. So also harm reduction kits. With the information that the numbers that came from this study, I think that it would be really good to put this information in harm reduction kits, small pamphlet, or, you know, and have them in there, because I don't think passing around harm reduction kits is harm reduction. We need, because I've worked and seen frontline workers just passing around kits, and that's not harm reduction. We need to be available as, you know, as to walk and to listen. So I don't know what else to say. I mean, there's so much I could say. I mean, I went to Insight in East Hastings to talk to the director once, and I was really interested. I was writing a paper on the Supreme Court of Canada, the health, the provincial and federal government headbutt over running Insight, and I wanted to go meet him. And he was one of the most amazing people I've met, so compassionate. And he said that what the problem is that this is pain. People are in pain. They're suffering, and, you know, people don't like pain. They don't like to look at it because it makes them uncomfortable. And you know, and that was basically all he had to say. So I think that, like, with what I've, you know, been thinking about lately is like, okay, you know, it's one, right? Like, people are burned out. Psychiatrists have like the highest burnout. Apparently, I've studied burnout. You know, of course, everyone's burned out, but at the same time, and which is not, it's not helpful for people who are seeking help to have people who are working who are burned out, because a lot of times the addicts are very sensitive, very fragile. And, you know, that's what, you know, harm reduction, trauma informed, it means do no more harm, do no harm. It means we need to be very, very careful with the words that we use when people are coming in to detox, recovery houses, rehabs. And we need to understand that the littlest feeling of not being included can set a person who's really coming off of drugs into either a relapse or into, you know, suicide. And that's the thing about benzodiazepines, is that they're tricky. And, you know, from my experience, I think in 2019 in Ontario, there was literally no withdrawal centers that were accepting people who wanted to come off of benzodiazepines. There was one, and that was like southern, eastern, and central Ontario. I don't know what it is now. I don't know if it's changed. I think it probably has. But people going into these places, you know, into withdrawal or recovery places, they should not have to be educating workers there on, you know, the actual withdrawal from the substance that they're going through. They need to feel like they're safe, that they're, you know, at that point in time, I do believe, you know, making your own choices and, you know, having your own agency is important. But I think that when, you know, it comes to that end of the road thing, that they need to feel safe. They need to feel like people know what's going on, and they know about this, how dangerous this certain, you know, drug is.
Thanks, Tasha. I think, you know, what you said at the end there around the need for multiple like services that meet the needs of multiple people, and for those services to have to be made in a way that's safe for people is so important, right? Because people need to feel safe and comfortable coming to services. You can't just have them. You have to make sure that they are accessible, and people want to be there and can be
and
there.
And it has to look attractive, because, you know, when one person goes there, and if they don't, you know, if they go back out and they're talking to their friends that they're using with, they're like, yeah, that place sucks. You know, it's like, I think that, you know, having like, even I've seen places with physiotherapy in their rehab, and this is publicly funded, right? Like, huge difference. I mean, there's tons of places that will take you for like $35,000, which is like, can you imagine a person with like 50 cents in their pocket, you know, looking for help, and they're like, yeah, it's $35,000. Like, well, yeah, I'm never going to be able to go to that, you know. And so, yeah, obviously we need to absolutely increase, not take down programs, not change them, improve them if they need improvement, and add. It's like there's just so much needed. That's like, I don't know what's going to happen, but it's just definitely not going to be pretty if we're not trying all approaches and looking at places that like have shown a really positive model. You know, like there's Portugal is like a big one that we keep talking about. Been reading about it. I'm not 100% sure what's going on with it. Obviously there's going to be controversy, but I think it just like we have to just sort of like pull our pants up and just say, or just be like, okay, well, we you know, you feel like giving up because of the burnout, but you know, the only choice we have is just keep going, and it sucks. You know, these numbers sucks. It all sucks.
I think that's a perfect way to end it. Is how much, you know, like how hard this is. I know there's a lot of questions in the Q&A. So
okay, like that sucks.
Yeah, maybe I'll pass it to Pam and we can kind of dive into some of those questions.
Okay, thank you.
Thanks, Tasha.
Thanks so much for all of your presentations and being able to make these data, you know, come alive with the community context and the stories that you've shared that really help us to understand. I'm looking forward to the discussion period together, and I'd invite people to continue adding their comments in the question and answer. I'm just going to combine the first and the third one because they're both about stimulants. And so I just wanted to, maybe I'll start with Tara for this. Are the stimulants pharmaceutical or non-pharmaceutical? And how do they contribute to deaths that involve opioids?
Yeah, I'll start and then happy to have Ashley or Tasha Dawn jump in. So primarily these deaths are occurring that involve non-pharmaceutical stimulants. So cocaine primarily is about 68%, and about half of them involve methamphetamines. So it's really, you know, much less than 20% of these deaths that involve pharmaceutical stimulants. These are usually deaths that are involving cocaine or methamphetamine. The question about the combined use. So the way that the coroner's office and the investigating coroners determine cause of death is that they look at the postmortem toxicology, and there are certain thresholds and clinical circumstances where they look for whether stimulants either alone or in combination with another substance contributed to the death. So without the stimulant there, the death likely would not have occurred. So that's why we often see stimulants and opioids together as both being direct contributors, but also there are deaths where we will see stimulants either alone or with other substances that are where the stimulant itself is directly causing or contributing to the death. And Ashley and Tasha Don might be able to speak more to this, but I know that they're tied to that. There have been questions around like, are people intentionally using opioids and stimulants together? You know, why would people be using these two drugs together? I know that at least from the conversations I've been part of, you know, the opioid supply is very sedating. So sometimes people are using stimulants to kind of counteract those effects. Or if they're using stimulants, they can sometimes use the opioids to help deal with some of the, you know, the anxiety that might come with using the stimulants. So I think a lot of the time that when we see both of these substances contributing to death, a lot of the time people know that they're taking both of those substances. Although we do hear anecdotally sometimes that, you know, the cocaine supply might be contaminated with fentanyl, for example. I think we hear about that, and that's probably happening to a small degree, but the majority of the deaths that are happening involving both substances are likely when people are intentionally using both. And that kind of comes back to the unpredictability of the supply and how people are forced to adapt their substance use patterns because there's benzos in the fentanyl now and you're highly sedated. And so all of those have trickle down effects to how people use substances and the risks that come with it. I don't know, Tasha, Don, or Ashley.
Yeah, I have so definitely sometimes you know, I think, well, people must understand that, you know, what's going on. And I'm like, well, no, not everyone has the experience where it's like yourself. A lot of people are, I should speak for myself, and many people know, is that you're self-medicating because there hasn't been enough help for, you know, that to help that person's looking for peace or calm. It's not like, oh, what they used to think about it is they're looking to get high and have fun and screw the world over and hurt people. And, you know, it's not. It's usually really amazing human beings, quite intelligent human beings, which sometimes is, you know, the cause of the addiction, right? It's the mind can't stop going. And so when the high is on, you know, like no dopamine, need to get high, like it, take it. And then it's like, okay, I want to come down now. This is too much. And then you take the benzo and you're like, well, I took this much cocaine, so I should probably equate the amount of benzos that I'm taking to like, and then it's like, had no idea how lethal that was, you know. Being able to for people to be able to survive and talk about that is like, that's a reality. It's like, okay, well, this is all I have. Thank goodness there's benzos. They're effective. They work. Thank goodness there's cocaine. It's got dopamine in it and I'm lacking. Like, it is all self-medicating, right? And a lot of it is. I'm not saying like that's, but yeah.
I think that's why it's so important also that we don't criminalize people for selling drugs, but work with people who sell drugs so that we can, like, you know, help educate. Because a lot of the times when I've seen people who only do stimulants and there's like fentanyl in it, it's usually those people who, like the people who sold those drugs, they don't even know, like some of them are kids. Like, really, there's some kids out there selling drugs and they have no idea what they're selling because they're just trying to feed themselves. So yeah, we have to do a lot of education with a lot of different groups of people. Yeah.
You know, I'd also say, like, we just keep going. We have like no other option, right? And keep adding and do the very best we can, you know, with it. It's so sad, you know. Yeah, it's like when you're talking about mixing, was very common, like was very common back when, you know, this is like 19, 20 years ago, right? And it was very common for people to mix. In fact, most people only mixed. That's like, you know, you're gonna have a drink, you're gonna go out, you're gonna take a pill, and then you're gonna do some of this, and you take some of this, because you gotta come down to this, and then, you know, everybody's gone, but you're still there. And where's the drug deal? Like, yeah, it's I think it's like, you know, that loneliness, that isolation. A lot of people are suffering and feeling, you know, pain. They're feeling lonely. They're feeling, you know, you know, like, oh, they've slipped through the cracks. You know, no one cares about them, and that is an incredibly sad place to be. You know, and I also know people who know that committing suicide isn't the easiest thing, and who say they're looking for that piece of carfentanil that they're out there, they're using, and they know that they can't successfully kill themselves necessarily, and so they want that carfentanil. So they're like walking around, literally looking for that piece that will kill them. And it's not funny. I'm sorry. I think I love the person I was talking to. When I think about him, he's just really a great person. Yeah.
Thanks so much to all of you. It's certainly complex around the combinations and being able to understand the context. I have the next question is on supports. I wondered if you can speak to whether there's more methadone clinics now than pre-pandemic in response, and maybe both the data and community perspective would be helpful here. Do you want to start first, Tara?
We haven't looked excessively at that, but as far as I know, there are not. I think that, the provision of methadone or buprenorphine across Ontario, the main ways it's changed, I think, are that there has been some expansion of, buprenorphine into family physicians' offices, like primary care. And there certainly has been a push for that because it makes so much sense to provide this within, somebody being able to see their primary care provider. I think we ask a lot of people to be going to an OAT clinic to manage any sort of access to treatment for an opioid use disorder diagnosis, while also, you have other health trainings, we all do, and having to go see another doctor for that, and it can be too much. So I think there's been efforts, but not enough, to integrate treatment into primary care. But I don't think that we have seen any sort of expansion of OAT clinics, at least nothing that I've seen, and I see Ashley shaking her head. I don't think we've really seen any expansion that way. And honestly, I think the best way to expand it is to expand it in primary care. It's not to open more giant clinics. It's to figure out how we can get more doctors prescribing methadone and buprenorphine, because that's how we can get it into all parts of the province, as opposed to having it all concentrated in these large centers. Actually, I've seen you kind of nodding. I don't know if you have anything.
Yeah. Do you want to go ahead, Ashley?
There's only one methadone clinic in my town, and people who use drugs keep multiplying, and that clinic doesn't multiply. So, yeah.
I'll skip to the second one on the list here because it's also on the, the supports for people. What would safe supply look like for stimulants?
In my opinion, it would look like cocaine, like how people get it on the street, but just not tainted, and without the all the cuts and stuff in there. Yeah, I think that's what it would look like ideally.
And I think
I agree. I agree. It's pretty disgusting with what they cut it with sometimes, and yeah, I mean, yeah, that's what it looked like, basically.
Yeah, my understanding is there's some programs that are prescribing methylphenidate, which is like a prescription stimulant, but I don't know too much about it, except to say that I'm not sure that that's really meeting the needs of what people want, right? And I think, to Ashley and Tashadon's point, with a safer supply for stimulants, a lot of what people need is actually just a reliable form of cocaine that they can access.
Thanks so much. The next one is about xylazine. So there was a New England Journal article on this, and seeing everyone's thoughts about the impact of xylazine in the drug supply. I wonder, Tashadon or Ashley, do you want to start with this, and then maybe Tara, if there are some of the data we can speak to.
I'll just say that I've seen a lot of infections with people who test positive for xylazine. And also there's a lot of that's all that they think they're taking fentanyl, and then they test it and there's no fentanyl, it's all xylazine. So yeah, I think that's pretty dangerous.
Any other thoughts from the panelists?
The Corners update where they look at the different contributors to opioid-related deaths. I think in kind of the first quarter of 2023 and for the last, probably year, about 2% of opioid-related deaths have had xylazine detected, which seems like a pretty low number. But I think what's really important and what I've been hearing, and this is a new area, but is that xylazine is less implicated in the toxicities and more so in these really awful infections that people are getting. And so I think when we think more about xylazine and the role that it has, we probably need to separate that a bit from looking at toxicity deaths and look at the other harms that it is causing, and trying to figure out, what that's going to mean, because, having these serious infections not only are incredibly painful, but can have really long-term, impacts on people's quality of life and pain and life in general. So I think it's concerning, some of the trends we've been seeing, and we need to make sure that we find ways to continue to look at this.
Great. We're starting to run out of our time here, but the next, I think we can fit this one in, wondering how people who are underhoused or precariously housed or homeless are captured in the neighborhood income quintile data or elsewhere in the reporting.
I can take that one. They're not well captured. The way that neighborhood income quintiles are captured is based on postal code tied to someone's health card number. But as we know, a lot of people who are precariously housed or are experiencing homelessness, they might not have an up-to-date address on their health card number. And so a lot of the time we really struggle to overlay those data with thinking about people who are experiencing homelessness. In some of our last reports, in the opioid-related data, we do have information on whether the coroner, based on their investigation, thought that the person was experiencing homelessness or precariously housed. And we do see a higher concentration of opioid toxicity deaths in that population. In this broader set of data, we don't have that level of information, so we couldn't specifically study it, but I think we could probably assume that there'd be no reason why. What we've seen in the opioid data, which is that our homeless population is one that is, disproportionately infected by substance-related harms. I think that would apply across all substances, and I think it was Tashibani and Ashley spoke to this. The need for us to think about how do we also provide programs and services to that population in a way that is accessible to them.
Yeah, there's a clinic in London, Ontario, and it was 24 hours, 7 days a week, open mental health services. And I was like, wow, that's absolutely amazing. Like, this is something that Ottawa's been talking about for a long time. And so when I moved back here, Ottawa didn't have it. And I was like, how do we not have that? London has it. Why don't we have a 24-hour mental health clinic, so people in mental health crisis have someone to talk to anytime they are in a crisis? They can go, right? I think that's something that most cities could. I think it's awesome to have that, a 24-hour, 7-day a week, just like a walk-in clinic, except they're specialized in like all the things mental health and homelessness, poverty. It's looks like a great program to have everywhere, all cities in Ontario.
Thanks so much, everyone. Unfortunately, I do need to bring us to a close, and we ran out of time, and there's so much to talk about here. We'll be able to send the other questions to the panelists afterwards that we didn't get to, and thanks everyone for your participation. So as we wrap up, thanking Tara, Ashley, and Tasha Dawn for presenting, and everyone for joining today. You'll receive a brief survey about today's session, and we encourage you to complete it and give us feedback on our programming. The Ontario Public Health Convention, you can save the date, March 26th to April 3rd. So coming up in the spring, and abstract submissions are open if you wanted to submit any of your work for discussion there. So we'll be able to post the presentation and also direct you to any of our past presentations and upcoming sessions on our website. And so thank you everyone, and have a good rest of the day. Take care. Bye.